Thank you, everyone, for joining us today. I have been looking forward to this conversation. Everybody joining and listening today has a vested interest in care and dignity of our population, whether or not that's through work and also your personal lives. Understanding the needs of those suffering from and caring for people with life-ending or life-altering situations. There is no one solution. Everyone will have different wants, needs, and desires for and from themselves, their caregivers, and their healthcare providers. Today, we are joined by two people who are passionate about not only the care that we provide, but the dignity and understanding of our patients and their families who they're providing care to. Dr. Harvey Max Chochinov is a distinguished professor of psychiatry at the University of Manitoba and a senior scientist for Cancer Care Manitoba, the Research Institute, and a proud member of the Canadian Medical Hall of Fame. Nancy Lefebvre is a senior vice president for the business of caring with SE Health, and Nancy is also a recent recipient of the Award of Excellence for the Canadian Palliative Care Association. For the most part, today will be a conversation between Harvey and Nancy. To start us off, I thought I would ask a question, and maybe I would go to you first, Harvey. Harvey, you have published many books and many papers, including papers with Longwoods and your most recent book, Dignity and Care, The Human Side of Medicine, which leads to my question. You are well known for your work on dignity. Could you tell us a little bit about your journey in dignity and how it has become such an important topic in your program in palliative care research?
Great. Thanks, Matt, and thanks for that opening question. It is a good place for us to begin the conversation. Years back when I began doing palliative care research and being a psychiatrist by way of background, I was interested in emotional experiences that patients were grappling with as they approached end of days, and began looking at a variety of things like depression, anxiety, desire for death, will to live, and depression. At the same time that we were doing this research, we were trying to follow what was happening in the literature and what was happening internationally in palliative care and in practices around death hastening, which took us to looking at what was happening in Holland and the Benelux countries. And the particular interest in trying to tap into that was not only understanding how often people were availing themselves of what the Dutch government referred to as medical decisions to end life, but trying to understand why is it people were seeking this out. And our supposition was that if we could understand why people no longer wanted to be alive, that might give us some insights, some clues into how we could provide better quality end-of-life care. And so we were looking at that literature, and one of the studies that came out in the early 1990s, published in The Lancet, first author was a man named Paul van der Mast, and they published the prevalence of medical decisions to end life, reported somewhere between 3 to 4%, depending on if you're looking at assisted suicide versus euthanasia. But then van der Mast did something that was really clever and interesting. He went to the death record of each of these patients who had access to hastened death and went to those death records where people had died as a result of euthanasia or assisted suicide, identified the physician of record, and then interviewed those physicians with the question, why do you think your patient sought this out? And this is where dignity first came onto our radar, because dignity and loss of dignity, more so than any other reason cited, according to these Dutch physicians, as to why their patients decided that it was time to end their lives. And so that was our clue. If dignity was worth dying for, dignity was worth studying. And at that point, we launched into doing some of the first empirical studies on dignity that needed to be done, finding out from the perspective of patients at the end of life, what does dignity mean? How do we understand it? How can we engage in it? And how can we use that to try and further, best practices in palliative end-of-life care.
So Harvey, where did things then take you from there in terms of some of the research and the kind of the outputs that you had at the end of the day?
Well, it's been a long journey, but it's been interesting because we ended up finding that dignity sort of was one of those gifts that keeps on giving. It really revealed some profound insights about end of life care and about more broadly the human condition. So we did both qualitative and quantitative studies. So we published a model of dignity in the terminally ill, which was, of course, informed by patients, which basically told us there are different domains of influence when it comes to preservation or the undermining or fracturing of dignity. So dignity is not the same to all people. There may be physical, there may be psychosocial, spiritual, existential issues that impinge or safeguard sense of dignity. So that was one thing that we discovered. One of the other interesting discoveries, and this was published as well as it happens in the Lancet, we discovered that one of the most ardent predictors of sense of dignity and these were large cohorts of patients who were approaching end of life, one of the most ardent predictors, in spite of having measured many different variables, pain, anxiety, depression, the notion of appearance or how people perceive themselves to be seen was most significant in determining whether or not people felt their dignity was intact. Now, for me, this was, extraordinary. It was really kind of one of those moments of epiphany in the course of my research, because it led to the insight that good palliative care is not just what we're doing with patients or what we're doing with families, but it has something to do with how we, the care provider, are seeing patients, how we perceive them. And what the data says, even though it sounds like I'm pontificating, what the data says is that is one of the most ardent predictors of sense of dignity. So I did a separate paper that I published in the Journal of Clinical Oncology called Dignity in the Eye of the Beholder. And and at least metaphorically, what I try and impress on readers is that patients metaphorically are looking in the eye of the healthcare provider for a reflection that will be affirming of their sense of dignity or will be affirming of their sense of personhood. Um, Additional places that the research has taken us to, we have developed something called the Patient Dignity Inventory, which is a way of measuring sources of dignity-related distress. We've developed a brief psychotherapeutic intervention coined dignity therapy, which is based on the notion of generativity, guiding people through a recorded and transcribed conversation that will allow them to bequeath to people that will soon be mourning their passing a document containing things that need to be said, providing wisdom, providing insights, providing words of love or forgiveness or whatever it is that people need said. We've developed something called the Patient Dignity Question, which is a briefer way of trying to elicit personhood by asking, what do I need to know about you as a person in order to take the best care of you possible? So those are some of the places over the last few decades that the dignity research has subsequently taken us through.
I think it's so important, and that the creation of some of the tools that you've developed really, I think, will help healthcare providers to jump right into that conversation. And even if it's, as you say, just the one question with the 15 seconds, but I think it's in, thinking about things from a home care perspective and nursing, I guess, and kind of coming from my perspective, but it's interesting because your comment about what's important is the appearance of how patients feel that they appear in the healthcare provider's eyes. And so we have a saying at St. Elizabeth that's all about the starting point. And so that would be the starting point of creating a therapeutic relationship, or one that includes dignity. And I think in some cases where we are guests when we go into people's homes, so it's really quite a privilege to be invited into somebody's homes at the best of times or at their worst of times, the beginning of life sometimes with newborns, and at the end of life at other times. And, we are able to go into people's homes. We see them dressed in their clothes. We see the pictures around them. We see their certificates hanging on the wall of their education. We see pictures of their grandchildren or whatever it may be. And we begin to very quickly understand what's important to them, what's relevant, what their history is, what their culture is, by pieces and artifacts that may be within the environment. And so our starting point is very different than, say, for example, in a hospital where we have people in gowns and are really more about their diagnosis than they are about people. And I think that what we've learned is that, it's maybe the first 10 minutes of a session, for example, with people who are at end of life, who need their pain management under control. But once that is addressed, that's really about 20% of the care. The other 80% of the care is all about them as individuals, their families, working with their resources and enabling those types of things.
Nancy, I'm going to underscore something that you said. You used the words "we see," and I think that is the profound thing that we need to kind of take away from this, and that is that if we see the individual,
Yep.
then we provide a gaze that is affirming, affirming of what? Affirming of personhood.
Mhm.
The reality is that even though we spend all of our professional lives, training to look after patients, no one wants to be seen just as a patient. And even in, our personal experiences, if you walk away feeling, just like a patient or another patient, the word patient is generic. It's based on an understanding of anatomy and physiology and the organ system that has gone awry, the heart patient, the kidney patient. So it is a generic way of understanding. And the problem is that we stop seeing the person. I tell an anecdote of a woman that I interviewed. She was a nephrology nurse. And I remember when I met with her and talked with her about her experience of being a nephrology nurse. She said that she knew that she was in trouble when eventually it struck her that after all these years, patients to her really appeared like, and this is a quote, kidneys on legs.
Right.
And the problem is nobody wants to be seen as kidneys on legs, because if all you, and it gets back to this reflection, if all the person sees is their diagnosis or a differential diagnosis or a problem checklist, they feel they've been reduced to what they have rather than being seen as who they are.
Who they are. Who they are. It's very true. It's that movement from, and you talk about it in your book, from personhood to patienthood, and the change in control, being in control, not being in control, not being vulnerable, being very vulnerable, being seen, not being seen, being interacted with on very different level in terms of that patienthood. I think of my father and his experience. He had his initial bout of cancer he was age 55. Now the great news is he lived to 90, but he did have 9 bouts of cancer. And it was very interesting, all, very treatable, but it was very interesting to see him move from being a person to a patient, and the frustration that he had with the lack of control he had over his own body and his experience and what was happening. And it's so interesting for us as the healthcare providers engaged with them. I was in his room one day, and I think of the 8 people that came in to the room in the hospital without knocking, the only one that introduced themselves to him and said, "How are you today?" was the individual that was bringing up the food tray. Otherwise, I had to interrupt everybody to say, "Excuse me, who are you and why are you here?" But one of his experiences was interesting. He was receiving chemotherapy or radiation therapy for 6 weeks, Monday to Friday. And he lived out of town. And so he had to come in 5 days a week, and live with my family and to receive his radiation treatment. And of course, it was it had a very big impact on his life. And he was a very busy gentleman and had lots going on and trips and plans and those kinds of things. So it was a real inconvenience for him, as well as a very great stressor and something that was out of his control. But the stories he always told were about the fights that he had with the individual at the front desk who was scheduling his appointments for him. And the two of them were always in a battle about when the appointment would be and what that would look like. And, I think if the individual, my father got very frustrated with this. And I think if the individual had asked him, why is it so important that you have these appointments at this exact time? Like, you need to be flexible. She would say, everybody else has having appointments too. And his point was like, listen, I have to come in from out of town. I'd like to have the last appointment in the day on Monday and the first appointment in the day on Friday, so I can come into town as late as possible and get out of town as early as possible. And the interesting thing was they eventually put a kiosk into the main room so that he could schedule his own appointments. And just that small perspective of giving him that level of control to schedule his appointments made a very different impact in terms of how he was interacting with the system, but then also how people began to interact with him as well. So.
Your story of your father reminds me of an anecdote I heard from a colleague. She was a radiation oncology clerk, and something very similar. There was an older gentleman who would ask for a specific appointment time, and those clinics are very busy. Yes. And stressful, and everybody, and be seen or seemingly seen as demanding, which is how she experienced him. And finally, she shared with me that one day she said, well, why is it so important? And he shared the fact that, well, it's so important because I'm looking after my wife at home. She has dementia. The home care provider can be there during these hours so that I can be here for therapy. It made an immediate change in the perception that this was no longer a demanding patient, but this was a loving husband who was trying to accommodate, to the needs of his wife and her home care. And immediately it felt something that she could easily try and I'm also reminded of a senior colleague of mine who at one time was the head of the Department of Medicine who during the time of his cancer treatment, he said, there were times he wanted to put a sign on his bedpost that read PIP, P-I-P, previously important person.
Yeah.
The other thing, and again, you mentioned, the person serving food. Anybody who has contact with patients is in a position to either provide or withhold dignity-conserving care. And so one of the things that I've written about, and I try and kind of say that, these are core efficiencies of anybody who has contact with patients. In physical health care, none of us are absolved from knowing the ABCs of critical care. Someone's unconscious, you clear an airway, make sure they're breathing, circulation, not bleeding. And none of us can say, well, that's really not my thing. I say, well, listen, if you're going to look after patients, it has to be your thing. When it comes to the humanities of care, we don't have any core efficiencies that we insist on. So I published a paper, I think it was in the British Medical Journal, called The ABCDs of Dignity Conserving Care, to say that if you have contact with patients, be aware that A, your attitude, that healthcare days makes a difference. B, your behavior based on your disposition. So do you stand or sit? Do you meet someone's gaze? Do you avert someone's gaze? And so on. C is for compassion. Compassion is understanding the suffering of another and responding to it. My previous postdoc and kind of world guru on compassion, Shane Sinclair in Calgary, says compassion is a verb. It is something that is combined with an understanding coupled with action. And D for dialogue, really referring to these conversations that affirm personhood. And it doesn't need to take a lot of time. Just finding out, so what do I need to know about you as a person?
Yeah.
To look after you well.
Yeah. It is really, dignity in care is really about showing up and being present. As you said, with the attitude and the behaviors and the compassion and spending the time to have the discussion with individuals to find out who they are. I know within our hospice we run a Journey Home Hospice, which is a hospice for the homeless population. And, in all environments, it's important. But when you look at end of life care, we only get one chance to get it right. And if we don't understand where individuals are coming from, and what's important to them and how they want to be seen as individuals and as people, it's very difficult for us to give them the very best care possible. We had a woman, and we have a video online about it. Her name's Nicole, and I always use this as an example because really strikes home with me. But the video is a view of Nicole, who did end up on the streets. But her comment was, 1 minute I'm a soccer mom driving the SUV with the kids in the back. The next thing you know, I'm addicted to OxyContin on the streets and dying. And so, when she came into our hospice, what she wanted to be known as, not as that individual who'd lost her children and became addicted and was, abused, came from an abusive relationship, which is how she got injured by her husband hitting her with a hammer in her back, and when she went on OxyContin. But she wanted to be remembered as, a soccer mom who loved her kids, who took them. You think about that saying, there by the grace of God go I, but really she wanted to be known as that individual, not the person that she had become because of life circumstances. And I think that's what life care is all about, is looking at the person, looking at the whole person, their life experience, what's important to them, and so much more than, as you say, the diagnosis or the illness or the treatment.
And also understanding that, the way we perceive individuals can be, at times misleading, because, all of us are raised in a particular way. We're socialized in a particular way to see certain things as having value and other things as having lesser value. If you think about the anecdote that you provide, it's very easy for us to see, her life as having reached a state of meaninglessness, of hopelessness, and to start kind of imposing, our own perceptions as a way of figuring out, what's the best recommendation for that individual. And this is something that I've written about. Intuitively, we kind of use the golden rule where we say, how would I want to be treated in that circumstance? What would I want done for myself or for somebody close to me? Which is an important moral adage, that we see in, many religious traditions across millennia. But it does make the assumption that our perception, the way we see things, is an accurate barometer of what patients are experiencing. And so when you think about the anecdote that you shared, we see her life as having been reduced to kind of loss and suffering. And so, how does that lead perhaps to a sense of kind of therapeutic nihilism where, geez, if I were that disenfranchised, if I were that marginalized, I'm not sure, that I would want to go on, or I'm not sure that life would any longer have any particular allure. So what I have kind of introduced into the literature is a concept that I've referred to as the platinum rule, which is to say, let's be careful, and let's do unto patients as they would want done unto themselves, which means we always have to confront our own personal biases, recognize that our perception, although a good starting point, may not be the accurate gauge of what that person's experience is. And it is of particular importance, if you speak to anybody, who is working in the disability community or read about disability studies literature, this whole dynamic of misperception around the quality of life and, ascribing a certain amount of suffering just based on disability, which really has to do with a misreading of, kind of our ableist gaze.
Yeah, it's interesting, and that perception goes both ways. If we think about that, as a healthcare provider walking into a hospital or walking into a home, patients and individuals and families also have a perception of us. So, I think, again, coming back to, where we begin and where we start our interactions with individuals do have an impact on where we will end up at the end of the day. So I guess in terms of, Sorry, go ahead.
I was just going to say that reminds me of another brief anecdote. This was a First Nations woman who had been a residential school survivor, and we were speaking with her. And one of the things she said, is that she said as a result of the experience, her family had moved, scores of times, and difficulties around trust. And she said, I don't trust people who walk into my room wearing a white coat. Because she makes the assumption that they won't tell her the truth, or they don't feel she's deserving of the whole truth. And what's astonishing to me is that, if we don't ask those questions, if we don't take the time to find out what's going on, even though, seemingly it's just another day, another part of the routine, we've walked into the room, but the whole subtext is something that we're completely unaware of just because we happen to be wearing our white lab coat.
Yes, that's very true. So one of the questions that's come up is around how can you uphold dignity of a patient for someone who is not giving direct patient care, but still interacting with the patient. And Harvey, you and I talked about this a little bit earlier, and providing care in the home, providing care in the hospital, or actually providing virtual care. How does one uphold dignity? And I think it comes back to really, taking a moment, could only be 15 seconds, but taking a moment to find out a little bit about the individual and to find out what's important to them and understand their wants and their whys and their healthcare journey and a little bit about them. So I think regardless whether you're giving direct hands-on patient care or whether you're having that engagement with someone through a telephone, for example, SE Health runs the 811 line here in Ontario. Those questions need to be asked in order to be able to establish that level of trust to be able to move on to provide recommendations and support for care. But I'm wondering if you have any other thoughts on that in terms of upholding the dignity of a patient.
Well, I think you've put your finger on it. I would also say that no one is absolved from the responsibility and I think the opportunity to be able to convey this kind of quality of care. And again, none of this need feel theoretical. All of us have encountered, when this works well and when it doesn't work well. The cryptic reception you might get from somebody at the other end of a telephone line, it's off-putting. Well, why is it off-putting? It's because you suddenly feel that, the individual that you are is entirely unique. There's never been one like you, and never will there be one like you. Whereas the moment you feel and hear that kind of tone, you realize that the uniqueness of who you are has suddenly kind of dissolved, and you are being seen as yet another patient, feeling like another cog in a wheel in a busy clinic. So I'd say we as healthcare providers, or anybody who has contact with those who are seeking healthcare, we need to be mindful that we're in a position to either provide or to withhold this kind of dignity-conserving affirmation.
We have a comment at SE Health. It's once you know one patient and one home, that's all you know is one patient and one home. And so you go into each one with an open mind. I guess in terms of supporting healthcare workers in the field, Harvey, certainly what we're trying to do is to look at additional training, additional support, tools that enable this care. And as I say, in our environment, I do feel it's a little bit easier, or it's a little bit more of a natural approach, because the individual, you don't have their diagnosis first, it's their name, their age, their family members, who they are, and then plus you're in that home environment. But I think of models of care such as in Journey Home Hospice, where they are in a residential hospice, where we've provided additional training in terms of trauma-informed care, culturally safe environments, psychological safety, and harm-reducing approaches to care. And I'm wondering, in general, in education, are we doing a good enough job in our healthcare providers' systems, nursing, physician therapies, in terms of including that in the education in terms of part of care? Or are we still fairly too illness focused to be making those changes, unless you go into a specialty such as end-of-life palliative care?
Yeah. Well, I think we can certainly do more.
Yes.
And not only is it that at times we become so illness focused, but we also get very kind of transactional focus. So, we think about, the event and the healthcare event that needs to take place in order to, be successful in that encounter, as opposed to the process that is involved in that. And, by way of example, and again, we've been sharing a lot of anecdotes, and this goes, years back when I was working on the bone marrow transplant unit. And seeing somebody who was not doing particularly well, and would see her each day on rounds. And I remember one day walking into her room, and the housekeeper was in the room sweeping, and I remember she looked up at me with tears in her eyes, and she shook her head and said, "She's not doing well today." And it occurred to me that this person has the sensitivity, to understand, the pathos of what's happening. And so what that means is that, I mean, she approached her job in a way in which it was not just about the transaction, but it was an understanding of the pathos, the human encounter. Uh, in other words, this person would never feel like, just another piece of furniture to be worked around. This woman, happened to be a woman housekeeper, um, treated this individual as somebody with a life, as somebody who mattered. Now, and you might say, well, why is that important? I think it's important on a number of fronts. Certainly, the vantage point of the person in the bed. No one likes to be treated like a piece of furniture,
Of
just
course.
kind of
Of
being
course.
dusted around. But it also matters, I think, from the healthcare provider or the healthcare professional perspective. If you realize that not only is what you're hired to do transactional, but relational, well, we have evidence that it increases job satisfaction. People
Yes.
who availed themselves of information about personhood actually reported heightened job satisfaction. So when you know that you're being put in a position not only to clean a room, but to interact with individuals in a way that can make a difference, you're going to have heightened job satisfaction and a less likelihood of suffering from professional burnout. So these things matter. I mean, they matter to patients, they matter to families, and to healthcare providers. And not only in terms of the clinical encounter, but when you look at the bottom line, this is going to improve reputation of the organization, and it's also going to safeguard the well-being of the healthcare team by making them less vulnerable to burnout.
Well, we know that happy healthcare providers provide excellent care and have very satisfied patients because they do have the time. And I guess that's for us in the healthcare system to look at what are the environmental barriers that we're putting up within our systems that don't enable, you know, care with dignity, and what are those things that we are actually implementing that are or supporting that do actually enable those environments. And I think one is the focus on lifelong care versus the treatment and the disease perspective, but also looking at opportunities to empower our healthcare providers to take those actions and have those interactions in spite of or be giving us feedback in terms of how we can change things around. I know we found a big difference in our staff in terms of the new model of care that we've implemented that is all about hope, opportunity, people, empowerment, engagement, and giving our healthcare staff the opportunity to be empowered as well to engage with patients in a different way and a different level within the time to be able to treat and respond to the needs that face them on every day. And as I said, once one patient is just one patient, but every day you go into the home, it's something different. Something different is happening for sure.
And what we're really talking about here is really kind of a cultural transformation.
Yes. Yes.
And if I had to kind of succinctly describe, what that transformation is, it's moving from a system of health care to a system of health caring. And the difference is, I mean, it may sound subtle, but it's really quite profound. And in order to be successful, it seems to me that not only is it something that we need to encourage, people who are, working at the bedside to be doing, this needs, I mean, cultural change needs to happen from the ground up and from the top down, so that um, it's not enough to simply, charge our clinicians and healthcare professionals to go out there and do this. They need to be working within healthcare systems
Right.
that value this, that reward this, because if not, it's impossible to provide dignity conserving care if you're working in an environment that doesn't feel as if it values that.
Yeah, yeah. No, you're right. And some of our healthcare environments are highly structured and are focused on throughput and output and moving people along. So I think that we do as healthcare leaders need to be taking a look at the environments that we create to support
And,
um,
and
and
I was
uphold.
going to say, and that kind of model may work well in the automobile industry, where there's sort of like this,
Right. Yeah. Yeah.
but it doesn't work. But it doesn't work well with people. I published an article called "Patients Are People with Feelings That Matter."
Mm-hmm. Oh, isn't that's very true. I think also we need to look at some of the structural determinants of health on care in terms of, access could be a good example where people experiencing homelessness and structural vulnerability, for example, have a very difficult time getting health cards or having access to health care. And then when they do come into the traditional environment, how they are engaged with, to your point, and how they are treated, and how their family or their street family is engaged or not also makes a significant difference. So on those individuals and the impact of their care as well.
So, Nancy, you just
Yeah.
kind of brought this up a little bit, and I'm wondering from maybe some other aspects, whether or not it be privacy or political or maybe financial, which you kind of just mentioned, but are there roadblocks that may kind of interfere in the sense of people being able to provide a sort of a dignity and care sort of program? Is there anything that's kind of blocking that or standing in the way?
Well, I mean, I think as Harvey mentioned at the outset, certainly the culture of an organization or an environment certainly stands in the way of being able to provide that type of thing. Certainly, the structural vulnerability and people are homeless in terms of being able to access it if they don't have a health card. Um, People with federal versus provincial health insurance are not always able to provide and access equally funded programs. I think there's experience in that respect. And I think it's the probably also the tools and education, both when you're in school, but also then when you're in a practice environment, there are tools that can enable the greater support of providing and upholding dignity of a patient than not, I suppose. I don't know, Harvey, your thoughts on some of that as well?
Yeah, no, I mean, I think that I think Nancy's pointed out, some of the roadblocks. I think there's also a kind of a certain. Well, first of all, I mean, there's the concern that if we are going to go this way, it is going to tax what is already a taxed healthcare system in terms of resources. People are always saying, we just don't have the time. There's not enough time to do this. And yet, I mean, it seems to me we can't afford not to do this because in the absence of doing this, patients suffer, families suffer. And we also know, I mean, and certainly just look at COVID, if you need evidence, the healthcare system suffers if we are not delivering care that is
Mhm.
attentive to dignity related concerns. I think there's also there are certain assumptions and certain biases that undermine our willingness and our ability to do this. The assumption is that just trust your gut. I mean, go out there, just be a decent person. Don't be a jerk. Just be a decent person, and it'll all work out well. And this idea of trust your gut, not everybody has a talented gut. The other thing is that there's an assumption that all of this ought to be kind of cost neutral. I mean, this is just talk after all. I mean, this is just the psychosocial, the pejorative, touchy-feely aspect of medicine. The truth is, in the absence of doing this, I mean, there have been studies that have looked at correlations between suicidality and dignity conserving care. The most ardent predictor of whether or not people become suicidal is the strength and the consistency of the relationship with their healthcare provider, even more so than psychotropic medication. So even though we may say, well, these things are kind of soft edge, they have very hard-edged outcomes. You know, if you get this wrong, these are the things that patients and families remember forever.
Forever.
Talk to ombudsmen, if you talk to people who are dealing with medical complaints, medical misadventure, very little. On the other hand, miscommunication, feeling like my dignity, my personhood was assaulted, those are the reasons why people are complaining, and those are the reasons why healthcare providers are most likely to face litigation.
Yeah. No, I absolutely agree with you. And it's interesting. I think the other concern that comes with this is time. People don't have time. They don't have time to do this. They don't have time to ask the question. And I think you and I were talking about it earlier. You have 15 seconds. How are you going to use those 15 seconds? You're going to ask a question about the individual and what's important to them, or are you going to move right on to their diagnosis? And so it's an interesting, I think, dilemma for some individuals when at the end of the day, it really doesn't take that much more time.
So we have 3 minutes left. So I thought maybe one more quick question and then some final, if you could give some final thoughts. So as the healthcare provider, as their role, how would they manage? So maybe dealing with a patient who is nearing end of life and they've chosen one care delivery plan, and maybe they change their mind and want to go to another care delivery plan. And what if the care team, their family, their husband, their mom, their dad, whoever it is, disagrees? And so just wondering how the provider might be able to handle that.
Well, I know. I'll let Harvey speak to this as well too. And I think it's probably spending some time to understand why the change in plan was decided in the first place, and to bring the family back to what was most important to the individual, whether it's their father or their mother or whoever it may be at that moment in time. What would they think their parent or their sister or their brother would be most important to them around the decision around this care plan, and why they would be making a recommendation for the change, and why they support it or why they don't.
And rather than repeating, what Nancy has said, maybe the aspect of your question I'll respond to, Matt, is to underscore what you said about, or choosing the example being end of life. And I guess what I want to bring us back to is that the things that Nancy and I have been talking about, dignity, personhood, respect, kindness, affirmation, even though, the research that I've done and the discoveries that we've tried and tools that we've tried to share come from the vantage point of palliative care, end-of-life care does not have a monopoly around those issues. Mm-hmm. Dignity and personhood, respect, all of these things apply across the entirety of medicine. So even though this is a palliative care focused conversation, these issues pertain to all of healthcare.
Absolutely.